Okay, so welcome to the call. So we're going to start off tonight by discussing some of the main concepts of level 3, and then we're going to basically bring Laura in and we'll do some demos on Laura. And the intention is I'm going to try and do some demonstrations of ligaments. We will do eyes, we will do hyoid, and Ognigen has asked me to do one thing. If I get a chance, I will, but I can't promise it. When I teach level 3, obviously we do indicator muscle testing, but there are some scenarios where you may come across a client that is globally inhibited, globally weak, and you cannot find an indicator muscle. So hopefully at the end of the call, I will very quickly just show you what you can do if that happens. So when I spoke to David about this, David, I think, would prefer that I show you if a client is neurologically normal, or if a client is globally facilitated, everything is strong but won't let go, or if everything is globally weak. So I'll show you that first. But what I will do is I will show you what I do if I have a client come in and I'm short on time and they're globally weak, so I don't have access to indicator muscle. And I'll show you what I do to basically do my variation of direction of dysfunction, so you can use that with scars and ligaments, etc., if there isn't an indicator muscle. Okay, so let's start at the beginning. So you've asked me some great questions. I'm going to hopefully mix in your questions into the call here. So a few of you, including Simon, have asked me a question about advanced gait pairs. So just to read the question here, Simon has asked me here about how, let's have a look here. The wording is, I don't properly understand advanced gait pairing. Can you give me a review on how it works? I suspect I already do this without thinking about it. Well, in level 2, you guys are given subsystems. So we have the deep longitudinal subsystem, the lateral subsystem, the anterior and the posterior subsystems. Well, in level 3, when I took level 3, Gary Ward of Anatomy in Motion was in the course. And Gary Ward and David Weinstock are very good friends. And David and Gary basically got their heads together and they looked at some more, not subsystems per se, because subsystems are based on the Vleeming slings, but looking at how we can look at muscles that are basically involved in transverse plane during gait. So the first thing is all the advanced gait pairings are based on muscles that are antagonists when it comes to transverse plane movement here. Okay, so what you'll notice is with all of them is they have opposing fiber orientation. So for example, if you look at some of the gait pairs that David gives you in the PowerPoint, for example, you may have the QL to lat pairing. Well, if you look at it, you're going to have, obviously on my body here, you're going to have the lat orientating on this diagonal versus the opposite diagonal with QL. So what you'll see is all of the advanced gait pairing muscles are diagonal muscles. And as you know, diagonal muscles tend to create a rotary movement as part of their action. So when you look at any of the gait pairings that Dave has given you, think of the fiber orientation, okay? Because for another example, you've got the iliocostalis erector versus the multifidus. Well, again, they're opposing, aren't they? Because you have the multifidus orientating in this diagonal, left and right, versus the iliocostalis on the opposite. So basically, they're antagonistics in transverse plane, and they're antagonistic in terms of their fiber orientation, because all of them, you know, any of the gait pairs that are in your PowerPoint, they are all based on the concept of, you know, for example, in the neck, the SCM orientating this way, where the scalenes orientate the other direction. So how do I use these? Well, a little bit like the level 2 subsystem, honest with you. So for example, if a client comes in and they complain of, let's say, a left long head hamstring dysfunction, I may think, well, the long head hamstring muscle is part of the deep longitudinal subsystem. So I tend to basically see if the muscle that they have the complaint in tends to fit one of the subsystems. That's how I do it. So just a few comments. So for example, again, a lot of tonight's call is going to be based on two basic entry points into level 3. I'm going to call it the muscle entry point, or the connected tissue entry point. So we'll talk about that later on here, but basically in level 3, we're gonna progress from looking at purely the muscular system and investigating dysfunctions that involve other tissues and structures. So we go into, as you know, ligaments, joint capsules, scar, etc. So with the advanced gait patterns, for example, if I have a client come in and they have lower back pain, and when they point to the muscle, it's the iliocostalis. Well, instantly I will think, well, a level 3 advanced gait pair is the iliocostalis. So I will then muscle test that muscle. So I'll test the iliocostalis in the clear. And if it's high tone, weaken the clear. Just like I say on level 1 and 2 calls, if a muscle is high tone and weaken the clear, it's very important because that is one of the two muscles in a pair. It's either the overactive or the underactive. Well, if it is the iliocostalis, I may then see if the multifidus on the same side is high tone to TL against it. Well, I'm doing that because I'm just recalling the advanced gait pairings. Or, for example, this morning I used it. I had a video link consult with another NKT level 3, and their client came in with nerve entrapment on this side here, basically nerve entrapment, and we found the scalene involved. So straight away, you know, we had a high tone scalene. So we begin with level 1. You know, we want to muscle test the symptomatic tissue. So we muscle tested the scalene, weakened the clear high tone, and instantly I said to them, have a feel and see if it is the SCM, because you guys know from the PowerPoint that the scalenes orientate diagonally this way versus the opposite direction of SCM. So therefore, I had them just go to the mastoid attachment spot for the SCM, TL, and it flipped. So that's how I use them. It literally is the same as level 2. If I have a muscle that is high tone and weaken the clear, and it fits one of the gait pair, I may actually then just see through palpation if it's involved. So they're very useful. It's almost like level 2 subsystems, just literally plug and play. But I guess the two big comments over those are, number one, that they are to do with transverse plane movement. So, you know, I think David goes through bottom to top. So you've got like the glute medius versus the piriformis, for example. That's to do with the hip rotation. So basically, they're all to do with transverse plane movement. And you'll notice all of them are to do with opposing fiber orientation. So if one muscle orientates this way, like the lat, then the gait pair may be the opposing direction, which could be the QL. That's why I use them. So one of the big concepts I want to talk about tonight is how do you progress from level 1 and 2 to 3? Because to me, level 1 and 2 are nice little step ups. You get level 1, we do muscle testing, you know, we introduce the use of TL, we do 2 basic testing protocols. We have directional testing, and occasionally you may use racial compensation. Well, that's literally level 1. And then we have a little bit of SCAR. Well, as you guys know, SCARs follow the same rules as muscles and ligaments and tendons, etc., dysfunctions. You're going to have a facilitated area or receptor, inhibited area or receptor. Okay, so the rules are still the same in level 3. But a big question I get asked a lot, and a lot of you have actually asked the same question in different ways. You've literally said, how do I take the level 1 and 2 knowledge and then the level 3 knowledge? Because to me, it's quite a step up. Well, in level 1 course, you guys have heard me talk about peeling the onion. And just a very, very quick review here. You know, when I learned NKT from David, he used to talk about peeling the onion. Well, I've taken that concept and basically looked at the rules involved. So here are the rules. We have a dysfunctional pattern, and right in the middle of the onion, you're going to have 2 things at play. We're going to call those the primaries. In other words, they are the middle of the onion. And there will be a primary facilitator and a primary inhibitor. They are the problem, and they're the only thing we need to really find and treat. Lol, another 10 minutes, please. So basically, you have the facilitated thing, inhibited thing. Well, can we now say that these rules apply to ligaments, to joint capsules, and, excuse me, so to ligaments, to joint capsules, and to scars? So here are the rules. Here's the first rule to learn tonight, okay? If you have a scar that is dysfunctional, around that scar will be a compensatory muscle layer. So we're going to call that a secondary compensation. So if you've got a scar pattern like a C-section, you're probably going to have in that scar a facilitated area, in that scar a related inhibited area, okay? There's the pair. But the rules are you will have around that compensatory, around that center, you will have a compensatory muscle pair. And you will have a facilitated muscle, inhibited muscle. So these rules apply to any of those, to the ligaments, to the joint capsules, to the scars. all of those structures, if they are dysfunctional, will have a compensatory muscle pair. Now, we're going to call that the primary muscle pair. So you have the primary in the middle, and then the primary muscle pair. Now, just like an onion, I need to, in my treatment sessions, find the middle two primaries, and I also find and treat the main muscle pair, okay? Now, with this, the more dysfunctional the pattern, the more layers of onion you will have, okay? So, I have literally had clients where when I've actually taken the time to map out the pattern, they can literally have multiple layers. And every layer of onion will have, technically, a facilitated muscle, inhibited muscle. You'll see loads of layers. Well, here's the problem. With level 3, we can find the middle of the onion in a few steps. But with previous levels, we don't necessarily have that to go on. So that's the big thing with level 3. Level 3 gives you the protocols and the testing tools to basically find the middle of the onion. So the rules tonight are going to be, if we find two muscles, we're going to see what may be beneath those, in the center of the onion, okay? So with this, all you have to remember here is the middle of the onion, you can have one facilitator, one inhibitor. Surrounding that ligament pair, or that joint capsule pair, or that scar pair, there is going to be a compensatory muscle pair. And if you can find both of them, that's what I treat. So for example, with a scar, I treat the two parts of the scar plus the compensatory muscle pair. Or if there's a ligament pair, I treat the two ligaments plus the compensatory muscle pair. Because what I found to be true is that if you do those two, you get a really good correction. And I then assign homework for those. So here are the rules. We're going to be looking for 2 entry points. Now, for example, if Laura comes in, I'm going to ask her the 5 questions. And if it is a symptomatic muscle that she gives me first, I'm going to start with the muscles. And what I do is, because my background is more soft tissue, I tend to find the 2 muscles. I will then do the level 3 testing, and I'll do TL both ways. I'll demonstrate that. So that's the second thing you learn level 3, is you learn how to TL both ways. We'll see the effect of that. And basically, I will find the 2 muscles. Now, once I've found those 2 muscles, I then may think, well, are there some ligaments that are more important? And I can show you how to find them. So we're going to do the muscle entry point, and those muscles will lead us to the ligaments, or to the joint capsule, or to the scar. Or the second route you can take is when a client comes in and you say to them, can you show me where it's symptomatic? They actually point to a ligament, or they actually point to a joint capsule. So I may actually, in that case, just go straight for that. But I'll be honest with you, just because the way I work as a soft tissue therapist, I have a habit where I tend to find it's a lot easier to find the symptomatic muscles first, because I can palpate them and test them. And then once I have the muscles, I can then use level 3 to see if there's a ligament that's involved, or if there's a joint capsule involved, etc. Okay, so few rules here. In order here, let's just talk a little bit about the muscle-to-muscle testing. So in the PowerPoint, you've got the advanced gait pairs. And what we tend to do is we tend to then mix in the new protocol. So what is the new protocol? Well, you guys have been shown that in level 1, you find a weak in the clear muscle, and your job then is to find another muscle that when you TL it, it flips the first weak muscle to strong. So we call it flipping, okay? So we use the term flipping tonight. So for example, I have a high tone psoas muscle, and I test it and it's weak in the clear. When in level 1, the idea is TL something else, for example, the QL, TL the QL, and it should flip the psoas from weak to strong. Nice. So basically, level 1 and 2, you guys are just shown if the muscle's weak to flip it to strong with a TL. When in level 3, we now introduce flipping the other way. So what that means is that you may have a pair where one of the muscles is strong. And what will happen is, if that muscle is high tone and strong, if you find the other one of the pair, this will happen. You'll TL the other muscle, and this muscle will flip strong to weak. So we call it the flip. So I call this muscle-to-muscle testing. So when's this useful? Well, this is a very good protocol to help you find the 2 muscles in that pair. Because in level 1 and 2, we basically are showing you how to walk first. before you can run. But in level 3, the protocol basically allows you to double check you've actually got, this is definitely the muscle paired with this muscle. That's very, very valuable, because then it means you're not going to find little offshoots. But there are rules involved. So in a dysfunctional pattern, talking muscles here, the more dysfunctional a pattern becomes, the more the brain will normally, as a protective mechanism, weaken the associated muscles. So in level 1, I always teach the students that you want to really value high tone muscles that are weak in the clear, because they are dysfunctional. Now, if they're high tone and strong in the clear, they're still valuable, but not as valuable, okay? But what you want to be thinking is, in an onion, the closer towards the middle of the onion you get, the more weakness you're going to find. So I'm just going to show you something here. So on this little board here, on this side, I've got the facilitators. So this is F for facilitators. On the other side, I've got IN for inhibitors. Okay. Now, as a pattern becomes less or more dysfunctional, if I share this one first of all here, this is basically the first possibility here. So you have a dysfunctional pattern that isn't that bad. And you have the facilitator on its own test strong in the clear. Okay, so it's dysfunctional because it's high tone, strong in the clear. And the opposing muscle, inhibitor, is also not that dysfunctional. So it's strong in the clear and high tone. Well, here's what we know. Using level 3 now, if I happen to TL the facilitator, it should flip the strong to weak. Now, that flipping effect tells you this is flipping this muscle. So the first step in level 3 is you TL one muscle, and the opposite muscle should flip weak to strong or strong to weak. So in this case, TL this one, this will flip to weak if it's paired. Well, in level 3, we added an extra step. We TL the other way as well. So in this case, I know these two are paired because TL the facilitated one, it'll flip the inhibited, strong to weak. Or if I now put a TL on this one, the same effect should happen. The opposing muscle will flip. Again, it'll flip it weak to strong or strong to weak. So that's very useful. So basically, when you have a true muscle pair, TLing the opposite should flip the muscle. Now, as this dysfunction becomes worse, it will literally progress to this. Well, the next step will be is the facilitator will go weak in the clear. Now, some of you know that in level 1, if you're a level 3 assistant, you sometimes wonder how I know as a level 1 instructor how the pattern is. Well, for example, if I have a high tone psoas, I test the psoas and it's weak in the clear. Cool. Well, I now say, for example, TL the QL. Touching the QL flips the psoas weak to strong. Cool. Well, if you let me test the QL, if the QL is strong in the clear, I already know the answer because the rules. How do I know that? Well, I know that the QL and the psoas are linked. The psoas is weak in the clear and the QL is strong in the clear. Well, basically, I found this one here. Now, in this pattern, here's what will happen. If I TL the QL, it will flip the psoas. Psoas weak to strong. Or if I now do level 3, if I TL the psoas, it'll flip the QL strong to weak. But already, because I found a pattern where one of the muscles is weak in the clear and one of the muscles is strong in the clear, I know the rules. The weak in the clear muscle is the facilitator. It's just the rules here, because what you find is the pattern deteriorates and becomes more dysfunctional. The first one the two muscles become weak is the facilitator. Now, if the pattern continues to become more dysfunctional, we end up with my favorite. Now, this is what I go hunting for, okay? So in my clinic, I'm looking for this. I'm looking for a muscle pair where the muscle is high tone and weak. I TL another muscle and the flip happens. But when I then test the second muscle I found, it's also weak. And I call this a double weak pattern. Now, this is the worst that muscle pair can get, because we have an exhausted facilitator that's run out of petrol. In other words, it's gone weak, and an exhausted inhibitor. Now, in this pattern, that tells me I'm getting very close to the middle of the onion, because as we talked about before here, the closer to the middle you get, the more weakness you'll have. Now, with this one, there's a nice phenomena that happens. if I have a weaken the clear facilitator and a weaken the clear inhibitor, a phenomena happens where you end up with what's called a locked muscle. Now, those of you that have taken Thomas Wells's NKT class, his integrated muscle testing and palpation class, in that class, Thomas talks about locked muscles. Now, he has a protocol for them. Now, I'm not going to show Thomas's protocol because it's taught in his class, but the phenomena is important because at level 3, if you start to find two muscles that are related, they're both high tone, they're both weak in the clear, they're very high priority to treat. And what you will find is in that phenomena, because of this neurologic dysfunction between these two, you'll end up where the brain will go to a local synergist and it will lock the local synergist. Now, what does Thomas mean by locked muscles? Well, locked muscles are muscles that are strong and in contraction, but then unable to relax. And that is the brain's way of basically trying to compensate. It's a functional compensation. The brain is trying to basically compensate for the weakness in the two pair. So I'm going to teach you as a level 1 how I found locked muscles. So again, if you've heard me say this before, just bear with me for 1 minute here. I'm just going to repeat for people that haven't heard this before. So here's how I used to find locked muscles. Example, client comes in and they point to their left adductor magnus. And I noticed 3 things with the magnus. Number 1, when I palpate the magnus, it's not an area that's high tone, the entire adductor magnus is high tone. It's what Thomas calls universally hypertonic. In other words, it's not an area of the muscle, the entire muscle. Now, if I find the entire muscle is high tone, that's my first clue, it could be locked. Number 2 clue is when I test that adductor, it will test strong. Now, I used to call these overstrong muscles because basically, rather than be a nice contraction relaxation, it's already in a contraction. It's almost like it's too early and it almost will test too strong. So basically it'll test very strong in the clear. And here's the first thing I found out when I was a level 1. I realized that a locked muscle doesn't provide a TL. So for example, I remember my very first week of level 1. I think it was on the Tuesday, I had a client come in with that complaint where he said to me, I'm always trying to stretch my adductor magnus and roll it, but it's always tight and won't let go. So I found a left adductor magnus. The entire adductor was high tone. When I went to test it, it was very, very strong and I couldn't understand it. So for about 10 minutes, I scratched my head and I just thought, I don't understand it. So anyway, I palpated around and I happened to find on the same side a very high tone pectineus. So I just went to the pectineus. So I did level 1, I found a high tone pectineus, did the muscle test and it was weak. And I thought, great, I got a muscle to start with. And I went to the TFL, the antagonist, and TL, the TFL, and it flipped the perineal, the pectineus, sorry. Level 1, so did directional testing and it turned out that the TFL was the facilitator and the pectineus was the inhibitor. So I just, did level 1 treatment and I treated the TFL, released it, activated the pectineus and thought nothing of it. So next thing, client walks around to challenge and it stayed great. And I just happened to, initially by mistake, palpate the adductor magnus and I didn't believe what happened. My hands told me the adductor magnus was normal tone. And for about a second, I didn't know what I'd done. Anyway, finished the session off, assigned homework. Anyway, client came back in next week and he said to me, the adductor magnus feels great. And I was like, okay, or did you stretch it? And he said, no, I just rolled out my TFL and activated my pectineus. And I suddenly realized, I didn't understand at the time, but I realized that the adductor magnus as a synergist was holding strong to compensate for the weakness. And because I'd normalized the TFL and the pectineus, it was able to let go. And it wasn't until I met Thomas back in 2014, he actually explained to me what was happening. So basically, a locked muscle is a functional compensation. It's a local synergist to the muscles. So basically, in that case, it was a synergist to the pectineus. So the main thing is by finding those 3, I learned one important thing. The first thing was I realized if I find 2 weak in the clear muscles, they're really high value. If I find 2 weak in the clear muscles plus a locked muscle, I'm incredibly close to the middle of the onion. So basically write down here that if you happen to hit a locked muscle or you happen to find 2 weak in the clear muscles, you are literally right in the middle of the onion. So my advice is go hunting for these weak in the clear muscles. Okay, so Laura's just walked in. We're going to get Laura on the table, tie your hair back, and I'm going to just see if Laura has an eye dysfunction, a hyo dysfunction, and a ligament dysfunction. So get up from the table, face up. Okay, so first of all, I'm just going to go through a demo here, and let's just approach, lie back, supine. I'm going to just basically approach here indicator muscles. So with this, I'm going to just show you how to find indicator muscle, because the level 3 indicator muscle protocol has 3 steps. The first step is find a valid indicator. The second step then is you can use the level 3 protocol to find 2 associated dysfunctional tissues or structures. So 2 bits of scar, or 2 joint capsules, or 2 ligaments. So let's look at the indicator first. So what does the indicator need to have? Well, first of all, there are 3 things I look for. Number 1, if you have a client with an upper extremity dysfunction, so anything above belly button, my advice would be is try and go away from the area of complaint for indicator muscle. So for example, if you had an anterior shoulder dysfunction, I'm probably not going to use your bicep. It's too close. It's going to really muddy the water. Okay, so if Laura has an upper extremity dysfunction, I'm probably going to use a lower extremity muscle as an indicator. Try and get away from the dysfunction. Okay, there's the first thing I do. Second thing is I want to look at gait. And let's say, for example, my client has a shoulder issue. I'm probably going to avoid any muscles that may be involved in gait. So for example, if I use flexion on this side, avoid the left leg. So I tend to try and avoid gait patterns because I'm trying to find indicator muscle that is independent. It's not part of the pattern, and on its own, it's nice and strong. So stay away from gait patterns, okay? Third thing is I will palpate the muscle. Now, any muscles that are high tone, I would say stay away from them. It's going to make it very complicated. So try and pick on a muscle that is normal tone. So some examples here. I commonly tend to use a few different indicator muscles. Now, in theory, you can use anything, but use muscles that you can repeatedly test here. So for example, I don't use things like the TVA. Why? Because it's against gravity. You're going to fatigue pretty quickly here. So I tend to find muscles that the client has a mechanical advantage. So for example, I'm going to show you some example ones I use here. So for example, I like to use things like distal quadricep. So with distal quadricep, I can test that 90-90. Now, if you pull knee towards nose for me, so breath in out and pull knee towards nose, strong and clear. So I tend to use distal quadricep. So again, on this side, very first step is going to be, is the muscle normal tone? So let's just cover the steps of indicator muscles. So number 1, for an indicator to be valid, I want to first of all make sure that muscle is normal tone. So Laura here has a really nice normal tone rectus femoris. Cool, tick. Step 2, as you've just seen, it tests strong in the clear. That's step 2. Well, spindle set technique, basically what it's doing is, in layman's terms, I explain to my clients that a normal muscle basically should be able to contract and shorten, relax and lengthen. Contract and shorten, relax and lengthen. Well, what a spindle cell's doing is basically it's sending a faulty message to the brain. Because if I shorten the spindle cells, if I shorten the muscle, the brain is getting an input of the muscle is shortening. So what then would normally happen? Well, if the brain has a signal, it's shortening, the brain will then respond by normally relaxing. So all a spindle cell is making sure things are normal. So again, we'll just do the muscle test. So breath in and out and then pull for me. Strong in the clear, cool. Second step, relax the leg down. Now I'm going to basically take the muscle. I'm not pushing down, I'm not putting pressure in. I'm going to basically draw the muscle together here. Now the main thing here is with the bent knee test, it's a distal rec fem test. So with this one now, I'll show on this side, I'm going to basically take the distal rec fem, I'm going to basically get some purchase and press together. Okay, now in college, I was just taught do it once. That should be sufficient. A few little things here. Don't do springs on it. If you do that, that's incorrect. Because if you do this, you may actually be cancelling out the effect, because if you shorten, lengthen, so avoid anything like this. Secondly, it's not down. It literally is just press together and you're done. So I'm going to do it on this side, Laura here. So I'm going to basically get some purchase. I'm going to press horizontally the muscle fibers together. I'm going to approximate the fibers. Okay, so take it back from Rex. I'm just going to just spin dorsal together once. Nice and strong. Breath in and out, knee to nose, and it should go weak. That's a normal response because I've fooled the brain. I've put a shortening input, and the response will be you contracted, therefore relax. So I could use that indicator muscle. Brilliant. Let's show you another one here. Let's use Laura's shoulder flex on this side here. So if I just have Laura have a nice straight arm and just pressure on that way for me. So take a breath in and out and push. Strong in the clear. Nice. So it's strong. When I palpate, they all feel normal, the shoulder flexors. So with this one, now, depending on the size of the muscle, I may use both hands to approximate the spin dorsal, or maybe one hand. I'm going to use one hand here. So I'm going to basically just approximate the shoulder flexors. Nice and strong, breath in and out, and then push, and it weakens normally. So Laura's testing normal. So again, quick recap, the muscles should be strong in the clear, normal tone, and a spin dorsal input should lead to a weakening output. It inhibits normally. Okay, cool. So indicators, we can use indicators for muscles that maybe are hard to reach or we don't have a direct test for. We can also use muscles for tissues and structures that don't contract, like scars, like joint capsules, like ligaments. So let's start our demos off here. So with this now, I'm going to ask Laura, we're going to try and find a ligament dysfunction with Laura here. So questions. Do you have any symptoms we can look at? Anything that feels tight in your body? Anyway. Left lower back. How long have you had it for?
Quite a long time.
Would quite a long time mean days, weeks, months, or years?
Well, over a year.
Over a year, cool. So again, over 6 months, cool. Can you show me exactly where it is? Show me where it is. Cool. So Laura's pointing to her left lower back. So I have a little palpate and just see what it is here. So bend your knees and hold them there. And just tell when I touch the tissue or structure involved here. So tell when I touch the thing. Is it there? Lower down, cool. Cool. So basically what I found there, so Laura's complaint is actually the iliolumbar ligament. Now, when I went into that area, I found a nice high tone spot on the QL, but the one she's complaining of is actually the lumbar ligament. So let's pause there for a second. Remember the rules before, that if we have a scar or a ligament or a joint capsule, there is going to be associated muscles. And with those associated muscles, they give us clues. So when I send you guys the video recording, I'm going to send you some of the selection of ligament to muscle associations. I will send you the ankle and the pelvis. So basically here, I know that the iliolumbar ligament has associated muscles, and one of them is the QL. So for example, if I was to find the QL muscle here, it would then lead me to think maybe the left iliolumbar ligament's involved, because you're going to have a ligament plus associated muscles. So the associated muscle to the iliolumbar ligament is including the QL here. So first of all, let's just find the muscle pair. So straight away, Laura has iliolumbar ligament left, high tone and hypersensitive, plus the QL. So let's start beginning here. Let's just keep it simple. Let's just test the left QL. Now, those of you that know me as a level 1 instructor, I always have a nice little habit. If it's the left QL, I will instantly palpate the right QL. And if the right QL is normal tone, I'll actually test it first for a number of reasons. Just to keep it simple for tonight, I'm going to say to you, if the right one is normal, I'm going to test it for 2 big reasons. Number 1, if that side is normal and strong, Laura and I then both have a nice baseline as to what a QL should feel like. I know the tone's normal, I know the test is strong. When we come to test the left symptomatic side, I can then know very simply, does it respond the same? Okay. Also, second thing is I always palpate the same muscle on the opposite side. because then I may also find it's high tone. So I'm looking for antagonistic pairing straight away. So I know the left one's the symptomatic side, but can I just see here with you, is there any tone on the right side? Completely normal. So I know left is high tone, QL plus ililumbar. The right one feels totally normal. So I'm actually going to begin my session off by testing Laura's right QL, just for comparison. Also in level 1, you may remember that bilateral equals core. So if I happen to find the left one is weak and the right one is weak, I then may be thinking core and spine. Now this is very useful because, for example, if I start off by testing your high tone left hamstring and the right one is also high tone, but they're both weak, remember the level 1 rules. Probably I'm going to be going towards the middle of the onion, towards the spine, for example. So let's start off by testing the normal tone right QL here. So the cues are going to be hold your legs together and keep pushing your lower body to your right that way for me. So breath in and out, and then push right for me. Strong and the clear. So that's a really nice response. So I know with a brand new client now how the QL should feel and how it should test. So my next step's going to be, let's test the high tone left QL. So again, the cue's going to be legs together and keep pushing your lower body to the right for me. So breath in out and then push left for me. Weaken the clear. Perfect. Now the moment I find high tone weaken the clear, I'm interested in that muscle. Okay, so right now on my board, I would write down left QL equals high tone plus weaken the clear. Well, my very next step is going to be almost using level 1 thinking here. I'm going to look for another muscle that when I TL it, flips the QL. Well, probably I'm looking at a local antagonist. So in level 1, I teach you guys is where's the second muscle? Most likely you're going to check for a local antagonist. If it's not that, I tend to think about things like maybe fiber orientation. So for example, I may think, well, the upper trapezius is diagonal and the QL's diagonal. And if I don't find that, the last one I go to normally is a local synergist. Well, to be honest with you, in clinic, I tend to find the first to find it. So let's look at some local antagonists. Now I know it's not QL to QL. I'm going to look for QL to front hip here with Laura. I'm going to have a look maybe if it's anterior hip or psoas. So coming to the front, yeah, there we go, straight away. Iliacus, dead simple. So let's start level 1 for a second. So can I borrow a finger here, Lon? And can you just touch that spot there for me? So Laura's going to hold a TL on her iliacus. Does that flip the QL that's weak in the clear right now? So TL gently, breath in and out, and then push left. Yes, it does. So TL to the hip flexor flips the QL. Well, the next step is going to be level 3. So I'm now going to go, okay, how does the iliacus test in the clear? Because I need to know how both start off, right? I know the QL's weak in the clear, so I'm going to test the iliacus. So iliacus, I'm going to take to 90 degrees, drop to 80, little bit of abduction. Now, I know in David's book, he said pull towards ipsilateral rib. I tend to say to the client, pull towards your nose. It's the same orientation here. So can you pull towards your nose for me? So breath in and out, pull towards your nose, and it's weak in the clear. Now, I get excited because all of a sudden, I've got QL weak in the clear, iliacus weak in the clear, and I think they're paired. So I'm actually getting a very important bit of information here. Both muscles are weak in the clear. So my next step with level 3 is, does TLing the QL flip the weak iliacus? So I'm going to just find a spot on the muscle first. Let's just have a little dig in Laura's back here until I find the spot. So I'm going to get hotter or colder. There we go. Can you reach around and touch that spot for me? So Laura's going to just touch. It's just inferior to the rib here. So we're on the QL. Use your fingers. So tell me if you can't find the spot. Found it? So TL to the QL. Does it flip the other way? So does the iliacus now flip? Should we see? So pull towards your nose for me. So breath in and out, and then pull. Yes, no, it doesn't. Okay, are you sure on the spot? Take a breath in and out, and then pull for me. Yes, it does. So basically, first time Laura's off the spot. So she's found the spot, just to double check for me. Breath in and out, and then pull for me. Yeah, she's on the right spot. Hand away, cool. So just a little bit off the TL spot to begin with. So what have we found? QL, weak high tone. Touch the hip flexor, QL flips. Nice. Try the other way around. Well, in the clear, iliacus is weak. So basically TL both ways. So I know TLing the QL flips the hip flexor. TLing the hip flexor flips the QL. Brilliant. Now in this situation, there's going to be a locked muscle. I'm going to find it for you here because I know that when the two muscles are paired, I've checked via the TL protocol, I've TL both ways. There's going to be a locked muscle, and the locked muscle has to be a synergist, okay? In this situation, in my head, my brain's saying to me, could be the psoas, or it could be a spinal erector. So look, I'm looking for a local synergist. So just bear with me here. And with Laura, it is the psoas. Brilliant. So the rules are the locked muscle is a compensation because of the weakness in the pair, the QL, the iliacus. So I'm going to show you here. Let's just see, because that psoas is very high tone. Let's test the psoas, okay? So in a moment, can you keep your legs straight and just push over that way for me? You ready? So take a breath in and out and then push me. Very strong, nice. So that fits my rules. It's a very high tone muscle in several places. The whole muscle's high tone. It tests very strong. Now I'm going to show you something here. In theory, TLing the psoas won't have an effect on the main pair. Should we show you? So just put a flat hand there. Good. So we're TLing the psoas. Well, if it's related, it won't do anything. Should we see? So can you, in a moment, pull your knee towards your nose? So take a breath in and out, and then pull for me. Does absolutely nothing. Hold the TL still. So we're on the psoas right now for TL. Push left strong as you can. Breath in and out, and then push. It is absolutely nothing. So I think there's my locked muscle. So my very last step here is not going to treat the locked muscle because I know that'll resolve itself when I get rid of the weakness in the pair. So we're now going to take a minute here just to directional test. Now, just like level 1, I'm going to test one muscle and see if the other one flips. So let's have a look here. Let's do iliacus first. So in a moment, pull knee towards your nose. So breath in and out, and then pull strong for me. We fire off the first muscle. How does the QL respond, shall we see? Breath in and out, and then push me. QL goes strong. Nice. So in this pattern, we have facilitated QL, inhibited iliacus, and a locked psoas as a compensation. Well, what are the rules? If it's double weak with a locked muscle, I'm in a very, very deep part of the onion. Well, now we're going to step into level 3 for a second. Okay, I'm going to see if ligaments are involved. Now, here are the rules. If there are 2 ligaments, they are surrounded by muscles. And I know the rules of TL. If I find a ligament here, if I TL the ligament and it's part of the same onion, it will flip the QL to strong. It'll flip the iliacus. And also while you hold the TL, it will normalize the psoas with palpation. Pretty cool, right? So let's see. Now in this case, after the call, like I said, the recording link, I'm also going to send you just some select ligaments. I can't say the whole body, but we'll just send you some. I will send you some common pairings in the ankle. I'll also give you some important ones from class. I'll give you maybe the inguinal ligaments. We'll do pubic symphysis. We'll do some of the posterior. I'll pick a few for you, okay? Now in this case, I know that the QL is related to the iliolumbar ligament. In the front here, I know the iliacus could be related to the inguinal ligament. So here's what I do here. I want to now, at level 3, see if there is a ligament pair that's driving it, and I'm only at the moment on the second layer of the onion, the muscles. So here's how I do it. I'm going to very gently here palpate Laura's inguinal ligament. I'm starting at the ASIS. I'm going to watch you jump off the table here. So relax for a second. There we go. So around about the midpoint on the inguinal ligament, there's a nice little high tone reflexive spot. So can I just get you to touch that spot for me? Whereabouts is it? Be very gentle here. There. So basically, you can't see this here. If I show you on camera, in the inguinal crease here, about halfway down the inguinal ligament. Okay, so Laura's going to hold with a single finger, just a very light TL to the ligament. Now, in theory, if this ligament is part of the same onion as the muscles, it will flip any associated muscle. Well, the QL is weak right now. The iliacus is weak right now, so should we see if the muscles flip? So hold the TL on the inguinal ligament, passive TL. Can you pull knee to nose for iliacus? So breath in and out and then pull. Yes, it flips it. Hold the TL still. Does it also flip the QL? So breath in and out and then push left for me. Yes, it does. Hand away. So basically, I know the inguinal ligament is in the same onion as the iliacus and the QL. Perfect. Well, if we stop for a second, there's a very important thing to show you guys. The ligaments now we can use indicator muscle with. So I'm going to, in a moment, find an indicator muscle and I'll show you the protocol to find the two ligaments. But can I just show you something? A few of you have asked me, what do I do if I do not have an indicator muscle? There are some scenarios where the client may be globally weak, and literally any muscle you test is weak. Well, as a level 1, I used to treat ligaments, and here's how I used to do it. I realized that even if Laura is globally weak, literally nothing, literally any muscle is weak in the clear, I have an indicator muscle. Well, there's 2 ways I can approach it. My advice would be at the end of the call, we'll spend a few minutes discussing what to do if you're globally inhibited. What I would do is look at the client's history, their movement and their cheats, and try and find what I call the magic TL. What I mean by that is, I would basically use a TL, and I would try to find somewhere on their body that when I held the TL, every single muscle I tested went strong. That is simple, because if you're globally weak, you're looking for the TL to the tissue or structure. So it could be a scar, could be a ligament, etc. Look at the history, take some context, and basically try and find a tissue or structure that when you TL it, everything goes strong. That is one of the 2 things you're looking for. So it could be a scar that flips everything to strong. It could be a ligament. It could be an eye. We don't know. But basically, that's simple. That's what I would do. Well, can we just say, for example, that you can't figure that out? Well, you can still treat the ligaments, because here's what you're going to find here. When I directional test these 2, I have found that QL is the facilitator and the iliacus is the inhibitor. Well, here are the rules in this pattern. The facilitated QL is compensating for a facilitated iliolumbar ligament. The muscle and the ligament mirror each other. So if it's a facilitated QL, then the iliolumbar must be the facilitated ligament. Whereas with the iliacus, if the iliacus is the inhibited muscle, it's a compensatory for the inhibited inguinal ligament. So even if the client has global weakness, what you do know is with the rules of muscles, if you directional test them, one will go strong. The one that goes strong is the facilitator. Well, with this type of testing here, I know that if I touch the ligament and the muscles flip, the chances are that I've literally, the muscle pair will tell me the ligament pair. So remember that rule. The facilitated muscle compensates for a facilitated ligament. They mirror each other. So in this case, if I didn't have an indicator, which is ideal, I want to do an indicator, that's the most valuable and viable way of checking it, I could actually take an educated guess. And I could release the iliolumbar ligament and stim the inguinal ligament. And what you'll find is if I have used the rules correctly and the pair is true, you'll find the muscles go normal. But one thing here, guys, the most reliable way with level 3 is using an indicator, because Thomas and David basically came up with the protocol. The idea is it validates at every step. So please use the indicator. It's the most valuable. Most reliable, sorry. So use the reliable method. Use mine as a backup, So let's just check that we have a valid pair here. So what I'm going to do, well, I need to first of all think, how am I going to practically do this? Well, either Laura's got to touch the ligaments or I've got to touch them. Well, I need one hand to test with. So basically, I have one hand available. Now, ideally, I like to have both hands. I'm going to use Laura's hands here. So in theory now, with Laura, she could actually use her right hand to get to the, can you reach to that? Yeah, she can reach to it. So she can use her right hand to go to the inguinal ligament. She can use her left hand for the lower back ligament. So let's start off our testing. So first of all, I'm going to use the same side rec fem. Okay, so I'm going to avoid the other side. So step 1, I want a muscle that is strong. So can you pull knee to nose? So breath in and out and then pull, strong in the clear. Perfect. Step 2, it feels normal tone. Brilliant. Step 3, I want to make sure that this muscle is not in a dysfunctional pattern with any of those 2 ligaments. So here's what we do. I'm going to have Laura put a passive TL on inguinal. And if the indicator is still good to use, the indicator will stay strong. There's no flipping effect. So use this finger here. So Laura's just going to use a finger. She's going to put a TL on the ligament. Yeah. So use TL. So basically she's going to TL. Now in theory, if it's in the same onion, it'll flip the muscle. I can't use an indicator. Should we see? So knee to nose for me. So breath in and out and then pull for me. And it flips it. So in this case, I can't use it because somehow that rec fem is part of the pattern. It's important to know that. So that is not a valid indicator muscle. Okay, well, let's try the hamstrings on this side. Number 1, hamstrings feel relaxed. Number 2, pull heel to bum. So breath in and out and then pull. They're strong in the clear. Brilliant. Let's try again. Can you put a couple of fingers and just TL that spot there? So reapply the TL, fingers crossed. Let's see what happens. So breath in and out and then pull for me. Nothing happens. So I have a valid indicator muscle. The passive TL just makes sure that no flip occurs. If a flip occurs, somehow that muscle's part of the pattern. So in this case, we're going to use Laura's left hamstrings. So I have strong hamstrings that feel normal tone, and a TL to the suspected ligament doesn't do anything. Brilliant. Can I make sure the same thing happens with your rear hip ligament? So I'm going to go on the back here. I'll do the TL here. So I'm going to just TL back there. I'm going to TL, passive TL, Laura's iliolumbar ligament. Now, hopefully, the indicator shouldn't flip, should we see? So heel to bottom. So breath in and out and then pull for me. Doesn't flip. Good. So this indicator is perfect to use. Cool. So passive TL should not flip. If it does flip, cannot use that muscle. Step number 1, I need to, first of all, find what I call the anchor ligament. Now, when I do the testing here, what you don't want to do is have hands on and off and on and off, because if you come off the right spot, the protocol doesn't work. So I'm going to use here the front hip ligament as the anchor. I will do that one for you. So basically, I'm going to pick 1 or 2 ligaments. So step 1, hamstring is ready to go. I'm now going to basically TL that hip ligament, whereabouts? Yeah, you got it, perfect. Now I'm going to cross fiber stim and TL the ligament. So I'm going to go stim, 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 TL. I want to see if stimulating and TLing the ligament creates a fault in the nervous system. So I'm going to go stim, 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 heel to bum, breath in and out, and then pull for me. It weakens indicator. So that says to me, the ligament you're touching is dysfunctional. It does not tell me if it's inhibitor facilitated. It just says it's dysfunctional. Well, the next step is going to be, I have to find what I think is the other ligament. So I'm going to go, okay, stim TL the front, indicator goes weak. Well, can I do the same thing with the iliolumbar ligament? Let's stim, 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 TL, and see if it causes a fault. I'll do this one for you as well. So I'm going to go to the back, and I'm going to find the ligament. I'm going to apply stim, 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 TL, breath in and out, heel to bum, and there's the fail. Perfect. So independently here, front hip and back ligament are causing dysfunction. Here is what's called the pairing process. I now need to see if these 2 ligaments are actually paired. Are they truly paired? And here's how we do it. I'm going to double stim at the same time. So stim, 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 and leave a TL on one of them. Now, again, props to Sue McCall for this. In the level 3 London class, Sue McCall is the level 3 study group leader. And she had a nice little saying, and she said, literally, it's like thinking positive, negative, they cancel each other. I like that. I'm going to steal that, Sue. So basically, when you double stim and TL, it's almost positive, negative, cancel each other. If these 2 are paired, what you should see is double stim TL1, and the indicator doesn't have a fault, it stays strong. That phenomena happens when you double stim TL and the 2 are paired. So here's what I'm going to do here. I'm going to have Laura TL the lower back for me. So go to that spot right there. We find the action spot. You got it? Perfect. I do the front one. Now what I do here is I tend to stimulate through the client's fingers. So I'm going to co-stimulate and then say to Laura, keep the TL in the back, passive. So stim both, passive TL. Let's do it together here. So give me a second, let me find the front one. You got it? So we're going to go stim, stim, stim. Hold the TL, indicator, breath in and out, and pull. Indicator goes strong, hands away. Basically, double stim TL, and if the indicator positive negative cancels, the indicator won't be weakened. Perfect. So double stim and TL, indicator strong means I've cancelled the effect, positive negative. My last step now is which one is the facilitator. So here's what we do. We're going to stimulate one of them and TL the other. Now, what we have to remember here is when you stimulate the first one, it will affect the second one. So if I stim the back and TL the front, whichever ligament I end up TLing, the indicator will tell me the answer. So just like level 1, when you do directional testing, if I stimmed the first muscle by testing it and the second muscle went weak, well, the second muscle is the inhibitor. So basically, think of the indicator muscle as indicating what the thing you're touching is doing. So let's have a little look here. So I'm going to very carefully here cross fiber stim the lumbar. So I'm going to stim, stim, stim. Hold a TL to the front, breath in and out, and then pull for me, and it goes weak. Now, because I stimmed the back ligament and I'm touching the front ligament, the indicator's saying weakness. So because the indicator's going weak, it's indicating that that is the inhibited ligament. I also double check. So I'm going to go the other way. I'm going to stim the inguinal and then touch the iliolumbar. Should we see what happens? So I'm going to stim, 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 which Laura loves. Stim, stim the hip ligament. TL the iliolumbar, heel to bum, breath in and out, and then pull. That goes strong. So because I'm touching the lower back ligament and the indicator's strong, if the muscle tests strong, it's facilitated, which means the back ligament's facilitator. Cool. If you notice there, my indicator's confirmed what my muscles told me before. The QL is the facilitated muscle, and the iliolumbar is the facilitated ligament. Cool. It's also confirmed that the inguinal ligament's inhibited, just like the inhibited iliacus. So I'm going to treat this really quickly. So for homework here, I would have the client find the spot in the back, treatment and homework, and basically we can just do a little cross fiber release. That will work perfectly. Or what I tend to do is I vector to find the best release. Now, one of you, I think it's Angela, asked me, could I explain a little bit about vectoring fascia and muscles? Well, here's the thing. When we have a mechanoreceptor involved, which you're going to find in NKT, often it's a Golgi. And basically, Golgi tendon organs monitor stretch. So whether or not it's a muscle or a scar or a ligament, it's the same thing. So as you guys know from level 1, in a scar pattern, with the scar, there will be a vector that you will feel a stretch in. That's exactly the same with muscles and with tendons. So what I do is I basically now find the ligament, and I'm now going to move the ligament longitudinally. So I'm going to see, is it this way or this way? I'm going to ask Laura, which way do you feel a stretch? I actually hold and vector in that direction, the direction of dysfunction, the vector that creates a stretch response for the release. Let's ask Laura here. So it's either going to be this way or this way. So look here. So where's the spot? You tell me. Down a bit. There we go. Is it when I press this way? Yes, it's this way. So again, I should put a little closer on her face here. This happened. So basically it's this way. So I'm now going to hold the ligament in the direction of dysfunction. I'm basically pulling it this way. This is the direction that she feels a stretch, and the Golgi is dysfunctional. If it's too much, give me a shout. She's loving this. So basically, I just hold it. So you can absolutely cross fiber it, but personally, I tend to, like a scar, I pull and I feel a stretch in the direction of dysfunction. Now, I'm going to hold this until it melts. It may take 10 seconds, it may take a minute, I don't know. I'm just going to hold it. So once this has happened, I'm going to release the facilitated ligament. I'm then going to cross fiber stimulate the inhibited and hopefully balance the pattern out. It's better, isn't it? Cool. So I'm now going to cross fiber stim the inhibitor to basically try and normalize it. So let's find the spot into here. Give me a second. There it is. I'm going to basically stim, 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 stim. Done. Now, in theory, if I've treated the facilitated ligament and the inhibited ligament, they should normalize the muscles. Should we see? So in the clear here, if I have a palpate now, Laura's psoas has gone softer. The lock muscle improved. Let's go the iliacus into here. That's improved. Now, I will know this because the two muscles associated should go from high tone towards normal tone, and the two muscles should test strong in the clear. Should we see? So let's test the muscles. QL first. Legs together, push left. Breath in and out and then push. It's strong in the clear. Perfect. Let's check the iliacus. So in a moment, pull your knee towards your nose. Breath in and then pull for me. Perfect. They're both responding normally. So for homework here, here's what I would do. I would show the client how to find the ligament, and basically I would have her just stretch it this way a little bit. Just, a tiny stretch. If she can feel a stretch sensation, that's the release done. Two options here. Now, with some clients, if they have good body awareness, I'd actually have them find the inhibited spot and cross-fiber stimulate it. Some of my clients don't have that body awareness. So what I tend to do as a backup is I will give them the iliacus exercise as activation, because I know that will activate the inhibited muscle, but also it will include a stimulus of the inhibited ligament. So, for example, if Laura maybe couldn't find the front spot very well, she could release the facilitator first until it relaxes, and then I could have her do this. Can you pull knee towards nose? So breath in and out and then pull once, breath in and out and then pull twice, and then breath in and then pull 3 times. Good. That will be enough stimulus to the inhibited ligament. That's good homework. So there's a ligament demo. Cool. So in 1 minute, let's quickly refresh here. Laura said to me, lower back symptom. We had a palpate. Her primary is iliolumbar ligament. I also felt QL. Cool. We tested the QL, high tone, weak in the clear. Nice. I went to a local antagonist and it happened to be iliacus. TL iliacus, QL, flip weak to strong. TL works that way round. Well, in level 3, we're going to do both ways. So basically then I went, okay, well, test the iliacus in the clear and it's weak and high tone. So then we had her TL, the QL, and it flipped the iliacus. Now, because the flip happened both ways, those are the 2 primary muscles in the pair. Nice. Also, because they were both weak, that tells me that it's a very dysfunctional muscle pattern and there's got to be a local synergist that's locked. Happened to be the psoas. Psoas was strong in the clear, universally hypertonic, and as you saw before, a TL had no effect. Perfect. I directional tested, and directional testing told me the QL was the facilitator and the iliacus was the inhibitor. Cool. I'd use level 3 to look for ligaments. And because I know that the associated muscle to the ligament is the iliolumbar to QL, I went to the iliolumbar ligament. TL, the back ligament, flipped the muscles. It's related. Or a TL to the inguinal ligament, which is associated to the front hip flexors, flipped the weak muscles. They're my 2 ligaments. I then broke out to a quadricep indicator. It was strong in the clear, but unfortunately, when Laura held a TL on the ligament, it flipped it, so I cannot use it. It's somehow part of the pattern. I went to the hamstring, and luckily, hamstring strong, passive TL to ligament, no change. We can use that. Next step, we stimulated and TL the front hip ligament, indicates that there's a fault, went weak. Perfect. We then independently stim and TL the back ligament, indicator failed, there's a dysfunction, there's a fault. How many of the 2 are paired? We'll use the pairing process, and that literally is you co-stimulate the 2 ligaments and TL one of them. And if they are paired, think of Sue's positive and negative. They will cancel the dysfunction. So double stim, TL, indicator now doesn't go weak. They're paired. My last step is what's called direction dysfunction. This will tell me which is the facilitator, which is the inhibitor. Real simple. Stimulate one and touch the opposite. Now, whatever you end up touching, the indicator reflects. So in Laura's case, stim the facilitated posterior ligament, touch the inhibited, and the muscle went weak. weak muscle equals inhibited ligament untouching. Or we do the other way around to check, stim the inhibited ligament and touch the facilitator and things go strong. Nice. So I'm going to speed up a little bit here because I'm now going to hopefully show you in the next 20 minutes an eye dysfunction plus a hyoid. So I'm going to keep these very to the point because of time here, guys. I apologize. So first of all, there are several ways to see if the eyes are involved. Can I show you the first one? Client comes in and there is weakness. I notice that if they close their eyes, the weakness goes strong. What's happened? Think of the eyes like video cameras. Left video camera, right video camera. If you see a client trying to shut their eyes frequently and eyes open, weakness, eyes closed, it negates the weakness, could be eyes. So here's what you can do. You can do two things. You can either close off the video camera, so occlude the video camera. So for example, client comes in, there's weakness, I think the eye's involved. Here's what I can do. I can occlude the right eye, cup the hand, but don't TL, and basically they can have the right eye open, doesn't matter, but they can't see through it. The optical nerve's not getting the feed. So for example, I have weakened the clear tests. I occlude the right eye, the brain now is getting feed via the optical nerve of the left eye. If I'm still weak, that's not the fix. If I cover the left eye and suddenly my muscles go strong, I have temporarily reduced the input from the faulty video camera. So should we see on Laura here? Now with Laura, before I had the call, I just want to make sure she actually did have an eye dysfunction. And I'm going to show you the second way. Now with Laura, she has a right eye dysfunction. That's all I know right now, because before the call, I did this. I got an indicator muscle. So I'm going to use maybe a hamstring here. I check the hamstring, it's normal. Can you pull heel to bum for me? So breath in and out and pull for me. Strong indicator muscle. Right now, both eyes are open, both getting video camera feedback. I'm now going to have Laura occlude and cover the right eye. So right now, she only sees the world through her left eye. If the left eye is normal, there will not be a fault with indicator. So we're testing left eye vision. Heel to bum. Breath in and out, and then pull for me. There's no change to indicator. Now you can really check this because I can, if I want to here, really challenge it. I'm going to have Laura basically move the eye up, down, left, and right, the primary muscle patterns. She's going to follow my hand here. So I'm now going to have her go up, down, in, out, and neutral. Look neutral. Take a breath in and out, and then pull for me, and there's no fault. In other words, hand away, there's no fault. She can look through the left eye, there's not a fault. She can move the left eye, there's not a fault. So the left eye is normal. Let's occlude the left eye. Now Laura's getting visual feed now via optical nerve of the right eye open. Her gaze is neutral, strong as you can. Breath in and out and pull for me, and there's a fault in the indicator muscle. Now hand away, relax. I know that when she uses her right eye, there's a fault. Now, right now, that fault is present when the eyes are neutral. So I know there's a right eye dysfunction. That's the entry point. So if you want to just see if the client has an eye dysfunction, is indicator muscle, yeah, and then basically occlude an eye and test, and occlude an eye and test. Perfect. Well, let's just show you the first version. Now, let's say Laura has weakness, and I, for some reason, think it's the eye here. You can actually TL the eye. And how you can do this is very simple, is obviously don't TL with the eye open. You can actually TL with the eye shut. Put a super light TL over the eyelid. And what you'll find here is that will often be a sufficient enough TL to flip the testing. So again, eye closed, very, very light TL with pad of finger and just TL the eyeball. That will often create a TL effect. So I can maybe TL, or sorry, the client would, sorry, not me, the client would TL the eyeball, that would create a flip. Those are the two main ways I know there are eye dysfunctions, either via an indicator muscle or TL the eye and things flip. So right now, I know Laura has a right eye dysfunction. What I don't know is the muscles involved and the direction. So when I finish the call with you guys, I'm going to send you a call link. And quick little bit of background here. When I took my level 3 class with David, I was stood watching David teach the class. And I had a notepad in my hand, and whilst Dave was actually teaching the class, I scribbled an eye clock. Now, I actually have this on my iPad right now. It's my original sketch. I will send you all this. So, very quickly, what is this? In your PowerPoints, you guys have Dave's daughter, and you will see him showing you the muscles that move the eye upwards. They're all on different pages. Well, I spoke to David recently, and he's asked me to update the PowerPoints, and I'm going to basically put a nicer version of this in. Now, what is this? Well, you're going to get a copy from me later on. This basically is an eye clock. And basically, this is me looking at Laura from her point of view. And I have written down all the eye vectors here. So we've got eyes up, eyes down, eyes left, eyes right. And underneath them, you're going to see little letters. And I've put like SR for superior rectus, for example. I've put letters corresponding to the muscles. So I know, for example, that if Laura looks upwards, that is using her superior rectus and her inferior oblique. So basically, I have all the different directions on that little chart there, which I'll send you. So here's what I can do. Right now, I know that if Laura covers her left eye, her right eye is causing a fault. Yeah, so in the clear, fault. I'm now going to basically like an active TL. I'm going to see if moving the eye up makes the indicator go strong, or down, or left or right. I'm going to basically find which vector flips the indicator. So Laura's going to look straight up in neutral. We're going to go to the heel pull. So breath in and out, and then pull for me. There's a fault. Now with this one, keep it very, very simple. I'm going to get Laura to use her right hand at arm's length. I'm going to get her to look at the palm of her hand. Right now, so in neutral, I'm going to see what happens here if I have Laura move and vector the eye downwards. So she's looking downwards. Does this negate the weakness? Breath in and out, and then pull. Very lucky guess. Relax, hands away. Lucky guess. Literally, it's downwards. So I would go down and test, up and test, left and right. Now you'll see in my little handout here, if you go up, down, left or right, you're going to test all the eye muscles. You can then fine tune it because it may then, for example, be down and to the right or to the left. But I know here straight down is done by the superior oblique and the inferior rectus. So those are my two muscles. So I know looking down, it could be the inferior rectus or it could be the superficial oblique. Those are my two muscles. Well, can I find a second direction that also creates a neural lock to the indicator? Well, probably the opposite's going to be down to up. So occlude your left eye, cover your left eye. We're now going to take Laura and we're going to have her move at 12 o'clock. Just so you can see it, not too much. She's now looking upwards. Does this also flip the indicator? Take a breath in and out and then pull. Yes, it does. Hands away. So I know that the two directions that flip the indicator are up and down. So now's my next step. Now, just for quickness here, you could absolutely use the cotton wool buds, but I'm just going to show you because often I have level 3s ask me, what do I do if I'm not a hands-on therapist? I'm a hands-off therapist. I'm going to show you the hands-off version. This can all be done with cotton wool buds, but I'm going to show you Laura. For example, if you're like a yoga Pilates teacher, for example, personal trainer. So what do I know here? I'm going to get Laura now, obviously nice clean hands. She's going to use her pinky finger. And we're going to basically go to the inferior rectus. And we're going to see what happens if we stim TL against the indicator muscle. Eyes are open now. So I'm going to hopefully here, rather than try and test all the eye muscle and randomly look, hopefully it's going to narrow it down here. So with your left pinky finger, I'm going to basically take the pinky to the 6 o'clock position, just below her eyeball. Common sense, not so common. Don't touch the eyeball. So I'm going to go to here. Now I'm going to basically this, I'm going to go stim, 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 TL. We're going to stim and TL the inferior rectus, which is one of the muscles that moves our eye down. I'm looking for a fault here. So we're going to go stim, 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 hold the TL. Does stim and TL create a fault? Breath in and out, hang a second. Breath in and out, and then pull for me. Yes, it does. Hand away. So I know on my whiteboard now, I can put down one of the two muscles is the inferior rectus because stim TL weakens. Perfect. Well, the inferior rectus is the looking down muscle. Well, I'm going to try and pair it with a looking up muscle. So the looking up muscles are the superior rectus and the inferior oblique. Well, can I just see if it's an inferior superior pattern? So we're now going to take Laura's finger to the 12 o'clock position in the orbital socket. So again, use little pinky finger. We're going to go just above the eyeball. I'm now going to go stim, 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 hold the TL, strong as you can with the indicator, breath in and out, and then pull, and boom. It also creates weakness, hand away. So I know the pair here, because I haven't had to dig around the eyeball, I've worked it out by using active TL movements. So up, made the indicator go strong, and the other way around. I then paired it with the two muscles. So it literally just makes me narrow down here. Now my last step is, my mistake. Second step is we're going to double stimulate and TL1. Now if these two are paired, double stimulus, TL should be plus minus cancel. Should we have a look here? So can I borrow that finger for the bottom of your eye? And can I borrow this one for the top of your eyeball? So 12 and 6 o'clock here. So I'm going to go stim, stim, stim. Hold that one there, do not move it. Heel to bum as strong as you can. Breath in and out, and then pull, locks indicator. So double stim, TL, indicator, strong. So we're touching the two muscles involved. We've basically co-stimulated them. I'm going to say to Laura here, keep the 6 o'clock TL. We're now going to only stimulate one of them. So we're going to stimulate the superior rectus and see if this one makes the indicator go weak or strong. So keep the bottom one still. Just rev up the top one here. So we're going to go stimulate 12 o'clock. Cool. TLing the inferior. Take a breath in and out, and then pull for me. Goes weak. Wonderful. Now, because we stimulated the superior and TL the inferior, and the inferior indicator goes weak, she's touching the inhibited one. So inhibited inferior rectus, facilitated superior rectus. Now, just for time here, guys, I'm going to do a very quick release. Now, this is where, if you're a hands-on therapist, you could absolutely, use a cotton wool bud. And what I'm going to do here is, because of time, I'm going to shoot a quick video tomorrow. I'm going to not run out of time here. I'm going to basically shoot a little video, and I'll take my time with Laura. I'll actually do it with cotton wool buds tomorrow, and I'll send you the link to that. I'll do like a 10-minute video. But if I didn't want to do with cotton wool buds, I can have Laura do it. So for example here, I could show Laura with clean hands. She could herself find the superior rectus, and then she could do some very, very gentle self-release. Or my favorite is to basically do pin stretch. So when I do eyes, I tend to accomplish the two here. I will do a little bit of cross fiber release, and then I'll have the client shut the eye, and then basically have them move the eye the opposing direction, and then you'll get a lovely stretch. So basically, it's a very gentle pin stretch. So with this one here, you would, we could do some cross fiber release on the superior rectus, and then have her close the eye, and then while she pins, she could go down to stretch. It works really, really well. To activate the inhibited muscle, here's what I would do. So I've released exercise number 1. Exercise number 2, I would occlude the eye. I would have a look at an object, which is roughly an arm's length away. And I would have her do this. I would have a look downwards 5 times. In other words, move the eye in the direction of the inhibition. We're going to move the eye down and neutral, down and neutral. That will stimulate and activate the inhibited rectus. So by doing that version, at no point do you have to, as the tester, be in the client's eyes, release the muscle or activate the muscle. The client does it themselves, but basically you're doing the muscle testing. So that's how I would do it, because I think 4 of you have asked me. 2 are yoga teachers. I think 1 of you is a personal trainer, 1's a Pilates teacher. You're quite right. You may not be technically covered in insurance. I don't know to ask your insurance company, because technically you're doing manual release. So that's how you would do it if you couldn't do manual release. Like I said before, I won't treat this now. I will grab Laura at some point in the next 24 hours. I'll bribe her again, and I'll actually put a video camera over. I'll actually show you a manual release with the cotton wool buds. She will have that done. I will also, guys, do a hyoid. Now, I've only got 5 minutes left here. I apologize. I will also do a Laura with a hyoid because she has a hyoid dysfunction. And what I will do is I will shoot a video, be about 10 minutes long. I'll just talk you through what I have prepared for tonight. One of my friends and an instructor, when they asked what I was going to do tonight, they thought I would never get through it all, and they're quite correct. I think a little bit too high expectations. I can't get through it all in one session. So I did promise some of you hyoid. I will do that in a separate video for you. I also promised some of you that I would show you what to do if the client is globally on or inhibited. I'll do that in the second video. So bear with me. Within 24 hours, I will grab half an hour with Laura and I'll just video those and I'll also send you those as well. Okay. Thank you. We're done. So I apologize. I thought it was a lot to cover in one call here. So let's take 5 minutes. So we've managed to cover muscle to muscle testing. We've managed to cover an indicator muscle, how to find one, how to validate it. We've managed to do ligament pairing with Laura. We've managed to also go into eye dysfunctions as well. So let's just grab 5 minutes here. And if you would like to unmute yourself, is any questions on what we've done tonight? I have some questions from some of you. I'm going to reply personally. But if you have any questions on what we've done with Laura, let's just take 5 minutes and basically shout out your name and shout out your question. So ready, steady, go.
Debbie.
Hi, Debbie. How you doing?
Hi, fine, thanks, Simon. A quick question on the global weakness. I've never found one of these before yet. So my question is, if you find your TL that flips everything to strong, how long is that going to last for you to then find a valid indicator muscle?
Well, you're not, are you? Because you're going to find people going neural states. Should we say it's like a spectrum? I will go a little bit in my separate video into why it happens. So I'll just go into the what's happening. It's like a spectrum. In the middle, you're going to have people that are neurologically normal. What that means is you will find some perfectly normal muscles. You'll find some muscles in their body that are normal tonic, and they can contract and relax them. Well, you can check that with level 3, can't you? Because you know a completely normal muscle, let's say my bicep, it'll feel normal, it will contract and relax. We can also check that using spindle cell. Because if a muscle's completely normal, this would happen. But, test my bicep, it's strong. Spindle cell, it'll go weak. Well, if they have at least one muscle working in the body, they're not globally inhibited. Inhibition can happen in areas. It could be local, could be regional, could be global. Well, just to make a statement here, I would say over 50% of my clinic clients come in and they're either globally off or globally on. It's a really common phenomena. But literally, if every single muscle's off, now, how do I know that? I tend to do what I call a round robin. So what I will do is, if I find your left arm is, let's say left arm weak in the clear, and your right arm is weak, and your left leg is weak, and your right leg is weak, if all 4 extremities are weak, you're globally weak. In that case, you need to TL something. Now, I say something because I don't know the client. I would use the history. So I may have, for example, fracture sites. I did a level 1 in Dublin this last weekend, and I will do a future study group on what to do with fracture sites because you actually treat them NKT. But for now, let's just say you can TL them. So we could TL a fracture site, a scar, a ligament, but I know from maybe asking the client questions. I'm looking for something to TL, that when I TL the thing, every other muscle responds to strong. Well, in that case, all I can say to you is what you're TLing is part of the cause of it. What I can't say at this point is, I don't know, it could be a scar or a ligament, etc. You can do, if you remember the beginning of the call, I said one thing, didn't I? If you watched the call back before, I showed you with Laura that if she had the QL to iliacus pairing and the whole body was off, I don't have an indicator muscle, but what I can do is I can find the 2 muscles involved. So let's say, for example, before Laura she wasn't, but let's say she was globally weak. And I found that QL and the iliacus were paired to each other. Well, even in a globally inhibited body, when you directional test, the facilitated muscle will flip strong. That at least tells me I can find the dysfunction in the muscles. Well, if TLing the ligament works, I don't have a ligament. So literally, that's what I do. So if you have a globally weak client, you won't have an indicator muscle. So just use the 2 muscles, directional test them. Remember the rules. The facilitated muscle is mirroring a facilitated ligament. In other words, that's how you find them. So I can't use indication anymore, but I can use the muscles to test that way. On the flip side, tomorrow when I do a video, you may get some clients come in that are literally just on, and you test them. I had one this morning with a guy called Joel at a level 3, and his client was a fun client because literally every muscle test is just on. And we knew that because when you test him, he's strong. Indicator, it doesn't go weak. And with this guy, it was a limbic dysfunction. So I will cover some of those tomorrow here. But yeah, I have clients that are in the middle where they're normal. Some weak, some strong. You can just treat them straight away. But if you have a client that is globally weak and inhibited or globally on and facilitated, you have to sort that out first. You're going to get very, very patchy muscle testing. But what I'll do, Debbie, is I will pretend on Laura. I'll show you what I do to find them.
Okay, thank you.
Cool. So guys, can I take 2 more questions? Specifically, what I've done tonight on Laura. Any questions on what I've shown you on Laura tonight on the actual patterns? Any questions? Please excuse me. I'm full of cold. Excuse me being a bit nasally.
I have one.
Who's that, sir?
Ogden.
Hey, how you doing? What's your question?
So, what if the vector of the neural lock is like showing that it's the obliques, let's say inferior oblique and superior rectum? Then the what would be the other? So, and then obviously the antagonists are the superior oblique and inferior rectus.
Rectus, yeah.
Sorry. So what are we doing with the pills?
Guys, everybody ignore the fact you said rectum. he said rectus.
Yeah. So basically, if we discover that the neural lock is pointing us to a superior rectus and inferior oblique, so the antagonists are superior oblique and inferior rectus.
Yes. Yeah, because basically, what do you know to be true? Well, Laura had a good indicator muscle, a hamstring, and we knew that it was a vertical eye pattern. It was up and down. So I went to my eye clock, and my eye clock says to me, well, the muscles that move it down are the superior oblique and the inferior rectus. So I just go, well, that's at least given me, it's narrowed down to 2 possible muscles. So in that pattern, if the stim and TL hadn't worked on the inferior rectus, I would have then gone, is it the other one that is involved, the superior oblique? Literally, it's a case of just my eye clock takes it from being all the eye muscles to being, it could be one of these 2. But at least then you know you're not going to be digging on the eye, because I then know that it's one of those 2. So there's 2 muscles with the eyeball down, it has to be one of the 2. A lucky guess, inferior rectus.
All right. So basically, from those 4 muscles, we're looking for like
the two. Yes, yeah, the two.
All right.
So what you're going to find there, guys, the most common pattern you're going to see, by the way, in clinic is going to be on one eye, and it'll literally be off an antagonistic movement. So it may be eye left to eye right, or eye up to eye down. They're very, very common. So literally follow a straight line. So you may have a client with, looking up this way to down this way. They are the most common pairings. So yeah, when you have the eye clock, the most common pairings I treat, by the way, in clinic normally are antagonistic pairings. So for example, I don't think logically you're going to have a pattern where it's the eye down to the eye down and left. It just wouldn't work that way. It's going to be antagonistic. So common ones I will see maybe vertical up, vertical down, or horizontal left, horizontal right. And by using the eye clock, in some of the directions, it's easy. So for example, if it's a horizontal eye movement, then I know moving the eye to left is only the lateral rectus. It's easy, right? But with some of the other movements, specifically up and down, there are 2 muscles that do it. So it's just trying to help you narrow down the field to then start assessing. Does that make sense?
Thanks.
Yeah, my whole concept then, KT, is I'm trying to create systems that rather than go, it's one of them, it could be these 2 or this one. It's almost like a system-based approach. I've just taken David and Thomas's work and just gone, can I give people a system? So for example, if Laura found that looking left and right created the change, I instantly know it's only 2 things. It can only be lateral rectus, medial rectus. So it's just trying to simplify the possibilities into, it could be these 2. But yeah, again, indicator's going to tell you, because when you find the first one, stim and TL will weaken indicator. It's a case of literally just taking your time. Now, normally with that one, you'll hit it first, second time, because if it wasn't the inferior oblique, I would have gone to the second muscle that looks down, which would have been the superior oblique. Yeah, great question, great question. Guys, can I take one more question? Have you got a question for me?
I have one more.
Yeah, please go ahead. Ask me one more. No, everybody else is being shy. Ask me a question.
Based on your experience, when we find the locked muscle, based on your experience, could it be that the local synergist to that locked muscle is always inhibited?
Okay, I'm going to smart that question. And I'm going to say that's covered by Thomas in his muscle testing course.
So I'm going to ask him because I did the course.
Yeah, because I have to be very, very careful here because I don't want to suddenly teach Thomas material, if that makes sense. So if you've taken Thomas's class, you have the answer already.
All right.
So yeah, I'm very, very careful here because Thomas has his class and he covers locked muscles. And as you guys know, he has a different protocol he uses. I'm just showing you the one I came up with as level 1, which is 3 rules. Number 1, it always tests strong. Number 2, the entire muscle's hypertonic. And number 3, there's no TL effect off it. I think that I'm safely staying away from teaching Thomas material. Does that make sense?
All right.
Yeah.
I'll ask them.
Yeah. It's, between you and I, by the way, ask on the private group you're a member of, because otherwise I'm starting to teach Thomas material.
All right.
Yeah, you remember the integrated muscle testing and palpation group, aren't you?
Yes.
Yeah. If you ask on that, if Thomas answers, I'll answer it for you on there. It's just I want to stay away from Thomas's material.
All right.
Cool. Well, listen, guys, thank you so much. So I always set very high expectations here, and I think I try to do too much in 90 minutes. So, like I said before, separately from this video call, I tomorrow will shoot another video, maximum 5 minutes, where I'll just show you actually treating Laura's eyes. I'll do it with some cotton wool butts, and I'll show you how to treat that way. I'll do a separate video with hyoid because I have a really nice way I do it. I showed David last year. I'm actually going to show you what I call testing the quadrants of hyoid. So I want to do a good job on that. So what I'll do is I'll do a nice video tomorrow. I'll explain a little bit about the hyoid anatomy. I'll explain about the quadrant theory, and I'll show you how I treat hyoid. But I'll do that in a nice separate video, just so we don't rush it at all. And then lastly, I will do a 3rd quick video, and I will just show you some common go-tos if the client is globally inhibited or globally facilitated. Just some ideas to start off with here, because ultimately, I can't give you the answer to every single client you're going to come across, because I've met the person. But I can give you some common things I try. There are 3 or 4 areas I tend to find cause that sort of global change. Okay, cool. So at least we got through muscle to muscle. We've done ligament, we've done eyes, and we've done a little review tonight. Last thing I say here before I end the call, don't forget the main concept that I teach in level 3, which is 2 entry points. You can either find the 2 muscles, you can do the level 3 TLing both ways, and then do direction dysfunction. And then when you find those 2 muscles and the answer which one's overactive, underactive, don't treat them. Leave them as they are. And then I will give you some suggestions of how you find muscle to ligament pairings. And then all you do then is go, okay, if I have the 2 muscles, don't treat them, start to TL the associated ligament. And if the TL to the ligament makes the muscle flip, you've literally, the muscle shown you where the ligament is. That's the way I tend to do in clinic. Or the second way is what Laura gave me, which basically she points to the ligament. So either way, you either go muscles first to ligament, or muscles first to joint capsule, or you just ligament straight away here. Both work for me. It's just having 2 different tools in the toolbox. Cool, guys. I must let you go because I've held you 10 minutes over here. So thank you so much for attending. Like I said, give me about 24 hours and I'll just do 3 separate videos, just so you've got 3 to watch here, because I didn't want to spend 5 minutes rushing it. So apologies for that. I thought I was going to do too much in 90 minutes. So I will do those 3 videos. So I'll send you the link to this video. I'll send you a link to me treating the eyes. You'll see me treat the eyes with Laura. I'll do one on hyoid, which will be hopefully very useful to you guys if you haven't seen hyoid being taught that way. And then lastly, I'll do a very quick video with some go-tos that I try if a client is globally inhibited or globally facilitated. Cool, listen guys, thank you so much for coming. Some of you are live, thank you for your questions. A few of you have asked me questions that are quite specific. So for example, someone said to me, my client has hammer toes on the left-hand side. that's quite a specific question here. So if it's a specific question, I'll probably answer just back by email here. But again, if you have any questions on the actual call itself, what I've done with Laura, just shoot me an email. So if you're not sure what I've done there or the step I've taken, just email me if there's a question about Laura's cases. Apart from that, thank you so much for coming. I will finish the recording off, and give me 24 hours. I will send you the link to all 4 videos. We're done, guys. Thank you so much. If you're in Europe, have a good evening. If you're in the other side of the world, have a good afternoon. Okay, we're done.